안녕하십니까. 온라인 서저리의 김경원입니다.
Greetings, I'm Dr. Kim Yong-won of Online Surgery. I'm honored to meet you. Let's take a look at today's case. This is a 75-year-old male patient. The patient had missing teeth in the upper left area from number 22 to number 26. The patient wanted implants to be placed in the upper left area, but the patient was actually wearing RPD. But because of it, the patient felt discomfort and there was gingival swelling at times. If you look at patient's medical history, the patient had hypertension and diabetes, but they were under control. Due to cardiovascular disease, antithrombotic agent was taken. The patient's medical situation is much more stable now. I didn't write it here, but the patient also smoked. From a different dental clinic, he was told that implant treatment was not feasible. As a result, a few years ago, the patient received RPD. If you look at patient's x-ray, in the case of upper right, implant treatment was received a long time ago. Long external type implants have been placed in the upper right, and you can see very long implants placed in the lower as well. The patient received implant treatment long time ago before the patient had an internal medical issues, and due to such disease, the patient has been delaying treatment. I consulted a doctor from internal medicine, and the surgery itself was not considered contraindication. So after controlling antithrombotic agent, surgery was determined. 3 implants were to be placed in number 22, 24, and 26. You'd see it in CT, but in number 26, there was not that many bone left. The OneCAS was planned. Digital guide would be used for sinus lift. In number 22, it was missing for quite some time, but you can see comparatively favorable alveolar bone thickness. The height is not a problem. In the case of number 24, there's a bit of buccal bone loss, but comparatively it was favorable. In the case of number 26, the height of residual alveolar bone is quite low. There's still lack of bone formation in the extraction socket. There was about 2 to 3 millimeters of residual bone left. If you look at CT, the sinus itself was clean. There would be no problem in using OneCAS. The patient had quite a long span bridge in the palate area and the alveolar crest area. 4 resin balls were made and merging was attempted. In number 22, the alveolar bone width was comparatively nicely maintained. A 4.010 mm TS3 implant was planned. In number 24, 4.5 by 10 mm implant was to be placed slightly deeply. There would be no special bone graft on the buccal side because the patient was smoking. That was the plan. In number 26, the residual alveolar bone level was not significant. 5.0 by 8.5 was planned, and the plan was to use OneCAS and to do crestal approach. Bone graft was planned as well. The shortest distance to the inferior margin of the sinus was 3.48 millimeters. Initial drilling of up to 2 millimeters was planned. The longest distance was about 4 millimeters, so the residual alveolar bone was limited. If we were not to use OneCAS, if residual alveolar bone height is under 3 millimeters, then doing 2 millimeter drilling can be quite difficult, but we have a very important tool called OneCAS and OneGuide. By using digital guide system, we can drill 2 millimeters as well. This is a sequence. The alveolar bone was considered to be soft bone, and the residual alveolar crest was considered to be 3 millimeters. After tissue punch, 2.2 twist drill would be used from 2 millimeters, so you would add 5 millimeter stopper on 7 millimeter drill. After expanding gradually, the final drill will be 3.8. gradual increase will be done. Sinus floor will be penetrated through hydrolift. The bone graft will be done, followed by implant placement. If you look at the upper right area, there is a significant prosthesis present. Through merging, surgical template was made and adapted. You can see that it has been adapted nicely. For a more sure fixation in number 24, vertical anchor would be used. If you look here, as planned, in immediate post-op image, number 22, 24, and 26 implants have been placed, and in number 26, crestal approach was used. AOS was used for bone graft. In number 22, this is immediate post-op image, and because the alveolar bone width was comparatively more favorable, 4.0 by 10 mm implant was placed. ISQ was 73 and 75, so quite good. In number 24, you can see that implant has been placed deep and ISQ value was about 80 in number 26. Despite there being lack of alveolar bone, you can see that bone graft was done nicely. And through crestal approach, the implant was placed and ISQ was about 77. It was more favorable than anticipated. This is post-op 2 months. And this is after 5 months. The ER-type prostheses were delivered. As you can see, initially the patient experienced a significant discomfort with a removable partial denture. We were now able to replace it with implant treatment, which was previously considered impossible because of medical history. Within a year, the patient came back. A panoramic image was taken. In number 26, on panoramic image, bone formation can be observed. On CT, in number 22, on the labial side, the wall is intact, and in number 24, healing is progressing without major problem. In number 26, although alveolar bone formation is not fully done up to the apex of the implant, you can see nice bone healing. Let's take a look at the surgical clip. One guide template was adapted. You can see nice stability with one guide template. Tissue punch was used in number 22. This is regular hole. Tissue punch was used to remove overriding mucosa. This was how it was done in number 22, and because this was a distal free end case, in order to make sure that the template does not shift, I applied pressure with my hand. Gingiva was removed in number 22 and 24. In number 26, wide type gold rim option was used. Overriding soft tissue was removed. You could see that I have removed the template to see whether the soft tissue was removed completely. In number 24 is slightly less properly done, so it was removed. It was done for number 22 as well. Initial drilling was performed while holding down the template in order to prevent any shift. In number 22, 3.5 by 10 mm drill was used to prep the site. 3.5 by 10 mm. In number 24, 3.5 by 10 mm drill was used as well. In number 22, one guided drill 4.0 by 10 mm was used. In number 22, because the implant with diameter 4.0 was going to be used, 4.0 drill was used. The TS3BA surface 4.0 by 10 mm implant was irrigated first and positioned. You can see here the bone quality looked quite nice.
퀄리티는 비교적 좋은 것 같습니다. 그래서 엔진을 가지고
It was placed about 80% using engine,
입을 하시고요.
implant driver, and torque wrench was used to adjust the final depths, and hex positioning was done.
를 포지셔닝하도록 하겠습니다.
Primary stability was over 30 Newton centimeters, so it was quite favorable. Through the yellow marking, you can check the implant position. In number 24, 4.5 by 10 millimeter one guide drill was used for final drilling.
시행하도록 하겠습니다.
In number 24, 4.5 by 10 millimeter implant was placed using engine about 80%. Stability looked quite favorable. Implant driver was used. Hand wrench was used to get final position. Primary stability looks quite stable. Yellow marking was used to adjust depths and hex positioning. Primary stability was over 30 Newton centimeters. Before moving on to number 26 and number 24, implant anchor was used. This was used as anchor because the residual alveolar bone in number 26 was only about 3 millimeters.
24번 부위에 임플란트
Using implant anchor,
스텐트를 확실하게
stent was fixated. In number 26, flattening drill was used first. Because socket did not fully heal, flattening drill was used.
사용을 했고요. 그다음에
The assumption was that residual alveolar bone was 3 millimeter. OneCAS drill, 2.2 by 7 millimeter drill with a 5 millimeter stopper was used. A 2 millimeter drilling was done. If we were to do it freehand, it would not have been easy to do 2 millimeters drilling.
지금 잔존치조골이 약 3mm 조금 넘기 때문에
Because the residual alveolar bone height is slightly over 3 millimeters, in order to do 2 millimeters of initial drill, on 2.2 by 7 millimeter twist drill, 5 millimeter stopper was added and 2 millimeter drilling was done. OneCAS 2.8 by 7 millimeter with a 5 millimeter stopper was used. 2 millimeter drilling was performed in this way. This would not have been easy if I were to do it freehand. Before moving on to 3.8, I used a 5 millimeter stopper on 3.3 and did a 2 millimeter drilling once again. 3.8 by 7 millimeter with 4 millimeter stopper was used for 3 millimeter drilling.
3mm는 넘기 때문에 아마 3mm
Because residual bone height was over 3 millimeters, I did not think that there would be any perforation.
4mm까지
With 3.8, I added 3 millimeter stopper and did drilling up to 4 millimeters.
다시 개통
I checked whether there was penetration using depth gauge.
4mm까지
Because drilling was done up to 4 millimeter, on depth gauge 6 millimeter stopper was added. You can see that the template is not fully in contact. Hence, you can get a sense that the sinus floor was not penetrated. 3.8 by 7 millimeter with a 2 millimeter stopper was used to drill up to 5 millimeters.
때 손의 느낌
While I was drilling, I felt that the sinus floor was penetrated. It's not really visible on the video clip, but I got the sense.
개통된 느낌이 있었고
Depth gauge with 5 millimeter stopper was used to check the penetration.
확인하기 위해서 지금 보시면
You can see that the stopper of the depth gauge was in contact with the template.
5mm까지 드링했을 때 개통이 된 걸 확인할 수
When drilling was done up to 5 millimeters, penetration was done and hydrolift was done thereafter. In 3cc syringe,
지금 보시면
0.5cc was placed, aspiration was done. You can see that there's blood upon regurgitation.
메인이 천공 없이
As a result, we could confirm that the sinus membrane was lifted without sinus membrane perforation. Negative pressure was observed. Bone graft was performed. Bone carrier was used.
콘덴서로 가느다란 콘덴서
Condenser was used to push it in gradually
사이너스 플로어 내에 크레스탈을 이용해
within sinus floor.
그래프를 시행하고 있습니다.
Bone graft was done using crustal approach.
사용하고 있습니다.
AOS, a bovine bone, was used. The AOS particle bone was placed gradually. Sufficient amount was bone grafted. Once again, hydraulic lift tool was used to do aspiration. You can see that there's a negative pressure and it doesn't come down. TS3 5.0 by 8.5 millimeter implant was placed after removing the last of cell line. There was a vertical anchor, so you can see that the implant was positioned very stably. Implant was placed about 80% using engine. Implant driver was used to get the final position. Because the vertical anchor was implant anchor, you can see that primary stability is sufficient. Yellow marking was used to check depths and hacks. The implant anchor was removed first. Smart peg was connected to measure ISQ value in number 22 first. In number 22, it was about 73 and 75. Number 24, it was almost up to 80. In number 26, primary stability was comparatively favorable and it was up to 77. Because crestal approach was done, healing abutment was chosen. In number 26, healing abutment with a gingival height of 6 mm was connected. In number 24, 6 mm height healing abutment was connected. As for anterior area, 4.0 by 7 mm healing abutment was connected. This was how surgery was completed. Today I've shown you how OneCAS was used. Although there was residual tooth in number 7 and template was fixed stably, because the residual bone height was about 3 mm and for safer procedure in number 24, implant anchor was connected and it was used as vertical anchor. OneCAS was used thereafter during surgery as mentioned. You would drill from 2 mm when there's 3 mm of residual bone height. If I were to do it freehand, it would have been extremely difficult, but by using OneCAS, I was able to place the implant in the desired position. 1 year follow-up was done and there was no major problem. Thank you for watching today.